On this tape, we will present to you a practical approach of 2D, Doppler, and flow imaging in the diagnosis and assessment of patients with mitral valvular abnormalities. We will begin with mitral stenosis. Traditionally and historically, echocardiography has enjoyed the status of being the gold standard for the diagnosis of mitral stenosis. With the addition of Doppler and flow imaging, the hemodynamic severity can also be confidently determined. For the patient with mitral stenosis, two-dimensional echocardiography allows us to assess the morphology of the valve. We specifically focus attention on leaflet mobility and calcification, and on the degree of commissural and subvalvular involvement. 2D echo also allows us to determine the mitral valve area by planimetry of the orifice. And we are also able to assess left atrial size and to scan the left atrium for thrombus. Of course, 2D echo also provides a means by which we can detect associated abnormalities, such as pathology of the other valves or atrial septal defect. This is the 2D echo from a 19-year-old female with mitral stenosis. In this diastolic frame, the aortic cusps have closed. The mitral leaflets are opened. Note that they are thickened, especially at the closing edges. The diastolic separation is reduced. The leaflets are tethered to one another, but the belly of the anterior leaflet, in this case, is very pliable and has moved toward the ventricular septum. This gives a characteristic hockey stick appearance to the anterior mitral leaflet. In real time, focus your attention on the characteristic motion abnormality of the mitral leaflets. The pathology slides in this series have been provided to us by one of our cardiac pathologists, Dr. William Edwards. Dr. Edwards has sectioned this heart such that we are viewing the left ventricle and the stenotic mitral valve in short axis. The mitral leaflets are thickened and the chordae are thickened and retracted. The commissures, posteromedial and anterolateral, are fused such that the diastolic mitral orifice has a characteristic fish mouth appearance. This can be directly visualized by 2D echo, as illustrated by this diastolic short-axis still frame from a patient with mitral stenosis. The dilated right ventricle and the flattening of the ventricular septum are indirect signs of pulmonary hypertension. The left ventricle and mitral valve both appear in short axis. Note the thickened mitral leaflets. Fusion of the anterolateral and posteromedial commissures has resulted in a severely restrictive orifice, which measured 0.8 square centimeters. In real time, the image will move slightly back and forth with respiration. Focus on the characteristic fish mouth appearance of the stenotic mitral valve. Here, the 2D image is again in parasternal short-axis format. This M-mode cursor has been directed across the anterior and posterior mitral leaflets, generating this M-mode pattern, which is characteristic of mitral stenosis. You will recall that the normal mitral valve leaflets are thin and that the leaflets move away from one another in diastole, with the anterior leaflet having this M-shaped appearance. This downslope, which is the E to F slope, is due to the rapid phase of left ventricular filling. To the right of the screen is the M mode of mitral stenosis. This is the right ventricle, ventricular septum, and left ventricle. The anterior and posterior mitral leaflets are thickened. Note that the posterior leaflet moves toward the anterior leaflet in diastole. This is because the leaflets are tethered to one another via commissural fusion. The E to F slope is less steep, correlating with the impedance to left ventricular filling. Here is another patient with mitral stenosis and a pliable valve. Note the thickened anterior and posterior leaflets and the reduced diastolic separation. The valve is now being viewed in short axis. The examiner will scan the valve until the minimum orifice is identified. The image has been frozen and the orifice has been traced, yielding a valve area of 0.73 square centimeters. It is not always possible to accurately determine the mitral valve area from the 2D exam. This is particularly true when the parasternal short axis image is suboptimal, when the leaflets are densely calcified, when the patient has had a surgical commissurotomy, or when there is extensive subvalvular involvement with a secondary subvalvular orifice. In this parasternal short axis image, both the anterior and posterior mitral leaflets are thickened and calcified. Short axis scanning will be performed in an attempt to identify the minimum orifice, but the orifice is not adequately visualized for tracing. This is yet another patient with mitral stenosis. The left atrium is enlarged. The mitral leaflets are thickened, and the diastolic opening is reduced. From the preceding long axis view, it would have seemed likely that we could simply rotate to short axis and planimeter the orifice and thereby accurately assess the degree of stenosis. However, this is the same patient imaged with the transducer positioned near the apex and tilted to inspect the subvalvular apparatus. This is the left atrium, and this is the anterior mitral leaflet. Note the marked chordal shortening and thickening. In cases such as this, the true minimum orifice is subvalvular and cannot be identified for planimetry. In real time, the transducer will be tilted from the subvalvular apparatus up to the tips of the leaflets. Patients with such severe subvalvular involvement are not suitable candidates for balloon valvuloplasty. Doppler evaluation of the mitral valve supplements the 2D exam. Doppler allows determination of the severity of stenosis even when the minimum orifice cannot be adequately visualized on the 2D exam. Doppler interrogation for mitral stenosis is performed with an apical or paraapical transducer position. This is an apical four-chamber view of a patient with mitral stenosis. The left ventricle is to the left of the screen and is normal sized. The left atrium is moderately enlarged. The right atrium, right ventricle, and tricuspid valve are normal. The anterior and posterior mitral leaflets are thickened with a reduction in the diastolic opening. Using the same apical four-chamber format, a Doppler cursor has been directed across the mitral orifice. The instrument has been set to the pulsed wave mode, and the sample volume has been positioned in the left ventricle near the mitral orifice. This is the resultant Doppler spectrum. The baseline has been shifted downward. In this case, the peak velocity is low enough that this simple maneuver avoids aliasing. The peak early velocity is 2.4 meters per second, and the velocity following the atrial kick is 2.5 meters per second. Note that the deceleration time is prolonged. An alternative solution to aliasing is to set the instrument to perform the duplex exam in the continuous wave mode. The Doppler cursor has again been positioned to cross the mitral orifice. The calibration markers are now at 1 meter per second, and the velocity peaks are again 2.4 and 2.5 meters per second, respectively. The continuous wave examination of the stenotic mitral valve can also be performed by placing the non-imaging probe at the apex. The small tip fits nicely between the ribs and yields a very crisp spectrum. This Doppler spectrum was obtained from another patient with mitral stenosis using this non-imaging transducer. The calibrations are 0.5 meters per second. The early diastolic velocity is increased to 2.6 meters per second. This is a faint signal of mitral regurgitation. Doppler examination allows us to determine the hemodynamic severity of mitral stenosis. The parameters which we routinely determine include the maximum gradient, mean gradient, diastolic pressure half-time, mitral valve area, and pulmonary artery pressure. We will discuss the determination of systolic, diastolic, and mean pulmonary artery pressures on tape number 9. On this tape, we will focus on the other 4 hemodynamic parameters. This is a schematic of the Doppler spectrum of mitral stenosis with atrial fibrillation. The timelines are 100 milliseconds apart. Because of stenosis, the early diastolic velocity is accelerated to 2.2 meters per second. Using the modified Bernoulli equation, we can determine the peak mitral gradient. 2.2 squared times 4 yields a pressure of 19.36 millimeters of mercury. By using the 4v squared formula for each velocity point along the Doppler profile, we can construct a curve, indicated here in red, representing the corresponding instantaneous pressure gradients, including the end diastolic gradient. Integrating this gradient curve and dividing by the diastolic flow period will give us the mean diastolic gradient. This curve can also be used to determine the diastolic pressure half-time. The pressure half-time, or T1 half, is defined as the time it takes for the early maximal pressure gradient to decrease by 1/2. Moving back to the pressure gradient curve we constructed, 1/2 of 19.36 is 9.68 millimeters of mercury. We locate 9.68 on our pressure gradient curve and then drop a perpendicular from this point to the baseline. We have also dropped a perpendicular from the maximum gradient point. The time from the maximum gradient point to the point where the gradient has decreased by 1/2 is the pressure half-time. In this case, 250 milliseconds. The pressure half-time is important because in most clinical situations, the mitral valve area is equal to a constant, 220, divided by the half-time. It is obviously tedious to determine the pressure half-time by constructing a pressure gradient curve. It turns out that we can arrive at the half-time directly from the Doppler velocity spectrum without converting to pressure gradients. In order to do this, we must be able to locate the velocity point that corresponds to 1/2 the maximal pressure gradient. By simple mathematical manipulations, this point can be expressed in terms of V max, which is a point that we can always locate on the Doppler spectrum. The velocity which corresponds to 1/2 of the maximum pressure gradient is found by simply dividing the maximum Doppler velocity by the square root of 2, which is 1.4. Returning to our schematic, we drop a perpendicular from the maximum velocity point. We now divide V max, which is 2.2 meters per second, by the square root of 2 and get 1.56 meters per second. We then locate 1.56 meters per second on the Doppler velocity spectrum. Finally, we have dropped a second perpendicular from the 1.56 meter per second point to the baseline. The distance between the two perpendiculars is our pressure half-time, 250 milliseconds. This is identical to that which we calculated using the more laborious pressure curve method. Using the formula for mitral valve area, 220 divided by the pressure half-time, we calculate a mitral valve area of 0.88 centimeters squared. It turns out that there is an even quicker way to determine the pressure half-time. We return to the same schematic Doppler spectrum. We have put a straight edge along the Doppler deceleration slope and drawn this extension, the red dotted line, until we reach the baseline, which is zero velocity. The time from the maximum velocity point to this zero velocity point is the deceleration time, in this case, 860 milliseconds. The pressure half-time can be closely approximated by multiplying the deceleration time by 0.29. Therefore, in this case, we would calculate the pressure half-time as 0.29 times 860 milliseconds, which is 240 milliseconds. This compares favorably with the half-time of 250 milliseconds calculated using the square root of 2 method. In our laboratory, we almost exclusively utilize this simplified method for determining the pressure half-time. This is a continuous wave Doppler spectrum from a patient with mitral stenosis. The maximum velocity has been identified, and a perpendicular has been dropped from it to the baseline. A straight edge was placed along the spectrum, and the deceleration slope has been drawn. This slope has been extended beyond the Doppler spectrum until it reaches the baseline, or zero velocity. The time interval between this point and our original perpendicular is the deceleration time, which in this case is 800 milliseconds. The deceleration time of 800 milliseconds is multiplied by the constant 0.29 to yield the pressure half-time, 232 milliseconds. We now divide the constant 220 by our pressure half-time, 232, to determine the mitral valve area, 0.95 square centimeters. Measurements of mitral gradients and mitral valve area have been greatly simplified by software packages that are available on many echo instruments. This patient has mitral stenosis. The continuous wave Doppler spectrum has been traced, and the deceleration slope has been identified. Using this information, the instrument has calculated the maximum pressure gradient, 20 millimeters of mercury, the mean diastolic gradient, 12 millimeters of mercury, the pressure half-time, 206 milliseconds, and the mitral valve area, 1.07 centimeters squared. In this same patient, the short-axis 2D view was used for a direct tracing of the mitral orifice. The area so obtained, 1.05 centimeters squared, agrees closely with the Doppler-derived valve area. Whenever possible, the 2D and Doppler methods should both be used to calculate the valve area. Using one as a check against the other will increase your confidence in the result. The diastolic pressure half-time determined by Doppler has been shown to be accurate when compared to the pressure half-time determined at catheterization. The half-time is reproducible, relatively independent of mitral flow, and independent of heart rate. However, there are limitations to using the pressure half-time as a measure of the severity of mitral stenosis. These include the fact that it is unobtainable in a few patients with poor apical windows. It is often difficult to measure the half-time in the presence of atrial flutter, AV dissociation, or a prolonged PR interval. And the half-time method of calculating mitral valve area has been shown to be inaccurate in the face of severe aortic insufficiency and also immediately after mitral balloon valvuloplasty. Having discussed the use of 2D and Doppler in assessing patients with mitral stenosis, we will now demonstrate the utility of color flow imaging in this setting. This is an apical 4-chamber view from a patient with mitral stenosis. This is the jet that is characteristic of mitral stenosis. The blue center is due to color aliasing. It gives the jet its typical candle flame appearance. Color flow imaging in mitral stenosis is useful in that the characteristic appearance of the jet helps confirm the presence of stenosis. Also, eccentric jets can be identified, which then allows the continuous wave Doppler cursor to be properly aligned in order to optimize the Doppler spectrum. Finally, flow imaging also allows quantification of associated regurgitant lesions. This is a 4-chamber view with the apex down. Note the marked left atrial enlargement. The mitral leaflets are thickened with reduced separation. This is the jet of mitral stenosis. Note the laminar coloration with increasing velocity on the atrial side of the mitral funnel. On the left ventricular side, the jet has been further accelerated, as evidenced by the regions of color aliasing. Note the mosaic appearance of the jet due to high velocity turbulent flow on this side of the valve. In this case, you can readily see that an apical Doppler transducer would be perfectly aligned with the mitral jet. The image has now been expanded with focus on the color jet. This apical 4-chamber view is displayed with focus on the left ventricle and a portion of the enlarged left atrium. Note the typical jet of mitral stenosis. Color flow imaging can help guide the CW Doppler exam. This assumes greater importance in patients with eccentric jets. A continuous wave cursor is now being utilized to interrogate the mitral valve. The jet allows us to see that the CW cursor has been misaligned, creating this angle, theta. Because theta is large, we know that this E velocity, 1.7 meters per second, underestimates the true E velocity. This is the same case, but the CW cursor has now been aligned directly along the color jet. We now see the true peak velocity, 2.9 meters per second. The spectral display has been frozen and the deceleration slope has been marked. The pressure half-time is 222 milliseconds and the mitral valve area is 0.99 square centimeters. This is an apical 4-chamber view from another patient with mitral stenosis. The thickened mitral valve is closed. This is the left ventricle and this is the right. The right atrium is moderately elongated, and the left atrium is huge. Notice the unusual echoes along the lateral and posterior left atrium and along the atrial septum. This is an example of a large thrombus in the body of the left atrium. This is a subcostal view from the same patient, with the right atrium here and the left atrium here. Rounded thrombus is again evident in the lateral left atrium, with laminated thrombus along the atrial septum. Mitral balloon valvuloplasty would be contraindicated in this patient, since the technique requires a catheter to be placed through the atrial septum. In this case, there would obviously be high risk of embolization during such a procedure. While standard external 2D echocardiographic examination is useful for detecting thrombus in the body of the left atrium, atrial appendage thrombi are best detected by transesophageal echocardiography. Combining continuous wave and color flow Doppler allows us to most confidently calculate the hemodynamic disturbance resulting from mitral stenosis. This hemodynamic information, coupled with the structural detail from the 2D exam, allows us complete, non-invasive assessment of patients with mitral stenosis.